Hello again. Assalamu alaikum. Good day to everybody. So today we are doing our vascular webinar session of Planetary Health Academia. Very grateful to the panelists and to the speaker and to the audience. So today we are discussing about elective open repair of abdominal aortic aneurysm. So we have emphasized on the term elective, and we're going to discuss the open repair technique of AAA, including its indication, pre-op assessment, complications and management of complications, operative technique. And on a separate session in future, we will discuss the endovascular technique of repair of abdominal aortic aneurysm, elective EVAR. So today we are privileged to have Dr. Jubair Ahmed, who is our associate professor in Ibrahim Cardiac Hospital in vascular surgery. He will be our speaker, and a very welcome to our panelists, and thanks again. So we have in our panel today Dr. Abidur Rahman, a very renowned surgeon from USA. Abid Bhai, thank you once again for joining with us today, and we're looking forward to get a lot of expert opinions and input from you on this very, very hot topic, I would say. We also have Dr. Maqbul Hussain. Maqbul, once again, welcome and thank you for joining us. So Maqbul is a very renowned surgeon in Bangladesh, vascular surgeon, is one of the pioneer in vascular surgery in Bangladesh. So we're also looking forward to get a lot of input from you regarding this open repair of abdominal aortic aneurysm. We have a very renowned cardiothoracic surgeon with us, Dr. Prasanta, and he is joining us from his car after finishing a long day. So that's why I have given him multiple thanks already. So Prashanta, thank you once again to join with us. And I know that you deal with aorta, both thoracic and abdominal. So looking forward to see, and get a lot of input from you, your experience in terms of open repair of abdominal aortic aneurysm. We have few audiences with us already. Welcome to join us in this webinar. And hopefully, we should be able to provide some information. And also, hopefully, our other panelists will join us soon. And other audiences will be joining us soon as well. So in our other panelists, we're waiting for Dr. Bashar, who is a very good vascular surgeon with a lot of experience, a lot of abdominal aortic surgery experience from NICVD. Professor Fida Hussain has apologized before that he has a personal event to commit. He will try to be with us later on, but if not, we know his problem today, his commitment today. I'm sorry to announce one sad news today that one of our panelists, Dr. Nirmal, Professor Nirmal Kantide, he unfortunately lost his father on last Friday. So let us pray for the departed soul of his father, and let's pray that Nirmal get enough strength to overcome this unsurmountable loss. So with that, I will request Dr. Jubair to start presenting your case, and we'll have some discussion after that. So Dr. Jubair, thanks once again. Please start.
Thank you, sir, for giving me the opportunity to present the topics today. Can you see my slide?
Yes, please. You can go on full screen. Yeah. Thank you.
Assalamu alaikum. Respected panel of experts and learned audience, welcome to all to this session. And I would like to give special thanks to Dr. Mohabub Qudus sir to give me the scope to present the topics, and definitely also give to the Planetary Health Academy to arrange such a wonderful program. So today's topics is elective open repair of abdominal aortic aneurysm. Myself, Dr. Juwar Ahmed, working as an associate professor and consultant, Department of Vascular Surgery, Ibrahim Cardiac Hospital. Yeah. So before going to the presentation, you all know this equation. And did you know one of the greatest minds in history succumbed to AAA? And this is Albert Einstein, died from an abdominal aortic aneurysm, a type of vascular disease that affects more than 7 lakh people in Europe. And abdominal aortic aneurysm, an expanding problem. So what is AAA or abdominal aortic aneurysm? An abdominal aortic aneurysm is a permanent localized dilatation of the abdominal aorta. The disorder is conventionally diagnosed if the aortic diameter is 30 millimeter or more, or increase in size of vessel 1.5 times normal diameter. If the size is 1.5 times more than normal, then we say the aneurysm. Why are AAAs a serious healthcare issues? In fact, in Bangladesh, there is no study about the AAAs, but an estimated 80 million people aged 60 years and older are at risk in Western Europe. So you say the number is too high. And AAA is the 12th leading cause of death in Western societies. It is a silent killer because there are often no symptoms that an aneurysm is developing in the abdominal. Epidemiology, incidence of AAA is estimated between 4 to 8% of male population aged 65 years or older. Comparatively, it is comparatively very less in case of females, 0.5 to 1% in the same age. And incidence of AAA has been estimated as a result of large screening program. In fact, if we have large screening program, then the incidence of AAA will be estimated. And incidence is growing as the population is aging. You know, the life expectancy, especially in Bangladesh, also rising. So the incidence of AAA is day by day increasing. Pathophysiology. Actually, I'm not going to the details. Pathophysiological changes in the aortic wall. In short, this is inflammatory process causing breakdown of elastic elements and which cause decreased tensile strength and leading to expansion. What are the main risk factors? Main risk factors: male, smoking for the smoker, hypertension, family history, increasing age, atherosclerosis, COPD, and another is infection or inflammation. AAA growth expansion stands highly variable. AAA growth accelerates with the diameter of the AAA. Aneurysm growth is influenced by risk factor. I already mentioned the risk factor. Now, what are the types of abdominal aortic aneurysm? Actually, there are different categories of types. Here, morphological classification is divided into fusiform and secular. And secular is more prone to rupture. This is divided into concentric secular, eccentric secular, and here you can see the picture of fusiform. So secular is more prone to rupture. Another type of classification, this is the depending upon the site. This is infrarenal, which is most common, justarenal, and suprarenal, originating immediately above renal artery, and another one, pararenal, involves one or both renal artery. Here you can see the picture: suprarenal, pararenal, justarenal, and infrarenal. And infrarenal is the most common one. Why is early diagnosis of AAA is so important? Because the operative mortality of treating a rupture aneurysm is around 80%. It's too high. For elective AAA cases, the operative mortality is drastically reduced, approximately only 2 to 7% of cases result in death. And AAA ruptures can be avoided by identifying the population at risk and conducting simple and inexpensive, just simple ultrasound examination. So it's very easier and simple test to diagnose a AAA. If untreated, the AAA may rupture. Here, this table shows the chance of rupture according to the size. If the size is 5 to 5.9 centimeter, the risk of rupture is 25%. And if it is 6 to 7 centimeter, the chance of rupture is, this is actually 5 years. The chance of rupture in 5 years is 35%. And if the diameter is more than 7 centimeter, you can see the chance is 75%. And you know the rupture, if aortic aneurysm become rupture, the mortality is 80%. So it's really very, very fast. Why do you have a decisive role in preventing AAA rupture? As a medical professional, you are the first to see the patient. No national or international AAA aortic aneurysm, especially in Bangladesh, except in the US. And a simple ultrasound examination easily detects anything. How can you diagnose a AAA? I think it's also very important. You know, for clinical feature, there is most of the cases we find it asymptomatic, no symptoms at all. Symptomatic can present with some spectrum. And in physical examination with palpation, pulsating mass is middle of the abdomen. And however, you may miss up to 80% of AAA because you will not get in palpation if the size is not too large, if that or the patient is not too thin and lean. If the diagnosis is limited to physical examination, then you may miss up to 80%. How can you diagnose the AAA? Ultrasound scan has proven to be a reliable and cost-effective way to diagnose AAA. It's very simple test and it is extremely sensitive test for all AAA sizes. It is painless and non-invasive. It is a cost-effective. Besides the ultrasound, for especially the management plan, we usually do the CT angio. Actually, we do the CT autogram, and sometimes we can do the in the catheter. So, who are the patients at risk? AAA primarily affect people over 60 years old or more. So, aged patients are more risk for AAA, and male are more risky than the women. And other some risk factor I already mentioned, the smoking history, hypertension, and family history of AAA. What if a AAA is diagnosed? When we diagnose a AAA, then what the protocol of follow-up? If the aneurysm diameter is less than 4 centimeters, then the follow-up annual. And more than 4 centimeters and less than 5 centimeters, the follow-up is every 6 months. More than 5 centimeters or symptomatic or growing by more than 1 centimeter per year, then we need to plan for intervention. It may be endovascular or surgical management. So today's point is elective open abdominal aortic aneurysm repair. So what are the indication of intervention? In general, if the size criteria for elective repair is more than 5.5 centimeter for men and more than 5 centimeter for women, and a 12-month growth rate of equal or more than 10 meters, that is 1 centimeter in both sexes, or any sizes of secular endome. These are the indication of intervention. Here already I mentioned the two treatment options, open surgery and endovascular stent cutting. Today's our topic is open repair of abdominal aortic aneurysm. So for open repair of abdominal aortic aneurysm, we need to patient the pre-operative assessment, and it's really very important. For pre-operative assessment, you need to take the proper history and clinical assessment first, then thorough evaluation. And in our country, we usually check the lung function test, cardiac evaluation. But in some countries, cardiopulmonary exercise test is very popular. I think UK This is very popular for the patient selection and planning for surgical team, pre-anesthetic checkup, and guard preparation. Cardiac emulation also main duty for open elective care. Operative procedures. Here I just mentioned the main things. I think Dr. Mahapudu sir will tell us the details. So first, the incision. It may be transperitoneal and rectoperitoneal. You all know the both incisions, some side effect and benefit. Then aortic clamping, sac opening, graftion, then aorta wrapped and closed around the graft, hemostasis and closed. In short, these are the steps of operative procedure. I'm not going to say in detail. So post-operative management. Actually, all patients should manage in ICU. In ICU, it will give you the advanced monitoring and immediate management if any complication arises. So for elective open repair patient, we usually manage at ICU. Now, post-operative complication. What are the post-operative complications? Bleeding, myocardial infarction. You know, there are around 40% mortality for aortic due to cardiac cause. So this is very important. And ischemia. It may be gut ischemia, especially transperitoneal abscess, lower limb ischemia, and also spinal cord ischemia, respiratory failure, renal shutdown by AKI, kidney injury, and venous thrombosis. These are the most common post-operative complications for open elective surgery. So, what are the advantages of open surgical repair? Already I mentioned the aneurysm open, graftion, and aorta wrapped and close around the graft. This is established procedure with more than 40 years of clinical experience. Include aneurysm and prevent sac growth, proven long-term result. Actually, if you compare to the endovascular to open, the long-term outcome is far better in case of open elective repair. And some disadvantage also the significant incision in the abdomen, 30 to 90 minutes cross clamp time, and up to 4 hours procedure. It may be longer and some contraindication. It may need 1 to 2 days ICU management, 6 to 7 days hospitalization, more hospital stay if we compare to the endovascular, and 4 to 6 years required time. Many patients consider unfit for elective open repair, like higher anesthetic risks, significant comorbidities, and previous abdominal surgery or hostile abdomen. These are the contraindication. And difficult recovery for patient, risk losing independence, high perioperative morbidity, and 5% risk of mortality. These are the disadvantages. Now, what is the typical patient follow-up for elective open repair? Following open surgery, ultrasound every year for patient treated with open surgery, and following endovascular state, we usually do the plain X-ray and CT scan at 6 months, and then annually for patient treating with endovascular stent graft. Which treatment for which patient? I think it's very important slide, especially for younger guys, because the decision is most important. Which treatment for which patient? This actually depends on case by case. This endovascular stent graft should be proposed to all AAA patients who are 70 and have an anatomy compatible with stent graft repair. And open surgery should be proposed to all patients and are fit for open repair. In patients with comorbidities who are unsuitable for open surgery against life expectancy. Now, some learning point. What is the main risk associated with an abdominal aortic aneurysm? I think you all know about the risk. This is the ruptured. And I already mentioned only 18% of patients with a ruptured AAA survive. Here you see the high, very high mortality rate. Survival rate is very low. So this is the main learning point, I think, for today's topics. And operative mortality in elective cases is less than 5%. Here you can see that drastically reduced with open surgery and less than 2% with endovascular repair. So this is very important, and it is also important to diagnose AAA as early as possible. What should I do with the patient at risk? An ultrasound examination may be performed or prescribed to check the presence of AAA. And palpation is not effective with all patients. So when we suspect or when a patient is risk, is a patient, definitely we need to do an ultrasound. Very simple test, we can diagnose. Thank you. Thank you for patient here.
Thank you, Jubair. A wonderful presentation. Very, very good. Very precise, concise. I like the way you started it, like Albert Einstein had this aneurysm and he died of ruptured aneurysm, which some of us know. It's a very important topic, and you have presented it well. We'll go into the operative detail soon. So I would like to invite any question first on this presentation of Zubair. If somebody has any question from the audiences, from the panelists, then we'll have some discussion from the panelists.
I have a question.
Please, yeah.
Regarding indication of abdominal aortic aneurysm open repair, the size, that is the 5.5 in case of men, and in case of women 5 centimeter. Yes. It is asymptomatic.
Yes.
But one thing, if there is symptom, on points perhaps that is missed. Symptomatic AAA, no question of size.
Yes.
So this point should be added.
Okay. So yes.
And what about the contraindication of AAA? Is it written anyhow?
The AAA open repair contraindication or?
Yes, open repair contraindication.
Already, sir, I mentioned the contraindications. Especially patients who are aged more than 70, multiple comorbidities, hostile abdomen, and unfit for open surgery.
So regarding indication, there is a missing point, that is the symptomatic AAA. No question about the size.
So Mokbul, thank you. So the whole intention of this discussion that we highlighted, that we mentioned elective open repair of abdominal aortic aneurysm. So it's elective means we selecting the patient, we decided beforehand to go. So when it comes to symptomatic aortic aneurysm, that's an urgent repair. That's an emergency or urgent repair. It doesn't stay in elective category anymore. But you are of course right that if it is a symptomatic aneurysm, and we have to repair it either as an emergency or as an urgency. So the best is to do it as soon as possible, but at least within 24 hours. So that comes when it is a symptomatic abdominal aortic aneurysm. In terms of the sizes, like the 5.5 centimeter, we'll discuss it a little bit more. There was a big trial, it's called UK Small Aneurysm Trial, published in Lancet in 1999. It's a big study, level 1 study, and the conclusion from that study was the risk of rupture on abdominal aortic aneurysm, if it is less than 5.5 centimeter, is very less, is around 1% or less. And when it increases to a size of 5.5 centimeter or more, the risk increases to 10%. So that is the threshold where the aneurysm need to be considered for an elective repair. In female, yes, there was some sub-discussion in that trial that because the female, the artery size are normally small. So the threshold in some center was 5 centimeter, but the overall consensus is if it is a female and you have an aneurysm, you need to select and judge the case on individual basis, because some female may have high BMI, and I'll always see that a lady with a high BMI has a small artery, and you need to correlate with this. There are other risk factors, there are cardiac risk factor, the risk of death. So we do not do essentially all female at 5 centimeter. It's an individual case to case, but the threshold for both sexes, we try to keep at 5.5 centimeter if it is asymptomatic. And that is supported by the UK small aneurysm trial. So we'll have more discussion on this. Dr. Abidul Rahman was like to ask something. I'm going to say
Yeah,
something.
I was asking you, but did I misunderstand? The risk of rupture in male is higher than the female, or other way around? My understanding was female has a 3 times higher risk of rupture in the abdominal aneurysm than the male. That's because, as Dr. Kudus mentioned, that the proportionate size of the abdominal aorta is smaller in general as compared to the male. So any increase is disproportionately increase the risk. So that will be my only comment on this aspect.
Yeah, no, absolutely, you're right, Dr. Abidul Rahman. The risk in female of rupture is much higher, and the incidence of death after elective aneurysm repair is also higher in female than male.
Exactly.
And so
Yeah,
that's why we need to be very, very careful when we're deciding to operate on female. So if we take it very plainly that we'll intervene when they're 5 centimeter, I mean, yes, it may have some benefit, but the risk would be higher if the patient is not entirely fit.
But why chance of rupture is more? Is it due to the wall thickness or anything else?
As Dr. Abidul Rahman sir has explained, because normally their size of the artery is smaller than the male arteries. Okay. So, to get a small artery up to 5 centimeter and to get a good size artery up to 5 centimeter, there is some difference, because if you think of proportion of the expansion in female, the proportion of expansion is much, much higher than their normal origin size of the artery.
Another thing you're telling, the symptomatic aneurysm, when it is symptomatic, then it is urgent or emergent operation. The patient has this symptom for 1 to 2 months. He or she has got back pain, the pressure symptom over the spine. Is it an urgent or emergent operation?
By definition, Maqbul, if somebody has chronic back pain for 1 or 2 months, then by definition, that pain is not from the aneurysm. Because if that aneurysm is causing that symptom, because the whole implication of a symptomatic aneurysm is telling you that I'm waiting to rupture, right? Because it's expanding suddenly, pressing on the nerve around it in the retroperitoneum, and it causing the pain. So by definition, when an aneurysm is symptomatic, it's telling us that I am waiting to be ruptured, and we need to immediately operate on it. So we do get this type of patient that has an ongoing back pain for a long, long time. And that's not the typical symptomatic aneurysm. So we need to see that aneurysm carefully. We'll probably intervene it sooner than the normal way. But that is not telling that these aneurysms. You agree?
Is it always available? Pressure symptom, it causes pressure over the ureter or duodenum or back. So is the increased size can cause pressure, but is it urgent or emergent operation by definition?
The commonest symptomatic aneurysm is abdominal pain, back pain, and tenderness on the aneurysm. So if somebody have those things with a sizable aneurysm, then yeah, we need to operate. You mentioned about a 4 centimeter aneurysm if it is symptomatic. We need to be very careful on those, because if this aneurysm size is 4 centimeter, it should not cause any symptom. And if it is, still causing some pain and tenderness, we need to very carefully look for other reason of abdominal pain. Because I have this experience. So one patient was having a 4 centimeter AAA, and he was having this symptom of abdominal pain, and the aneurysm was slightly tender. And, it was a very difficult decision. We could not find anything. And then, we operate on that patient, and, his pain didn't go. So after lots and lots of investigation, we found that he had some biliary problem. So we need to be careful. And I would be very hesitant to do an aneurysm repair on a 4 centimeter aneurysm, even if it is symptomatic. It is probably not symptomatic aneurysm. It's something else. We need to do intensive investigation to find it. What's your opinion, Dr. Abidul Rahman, on a 4 centimeter aneurysm? Could it be symptomatic?
I fully concur with you. If it is a pain and you think it's related to the abdominal aneurysm, especially the aneurysm is not that big size, then you need to have extensive evaluation for other causes of abdominal pain. The things you mentioned, ureteric obstruction, duodenal obstruction, they'll have a definite symptoms related to that. And also, if there's a back pain, specifically back pain, that is not related to a spinal musculoskeletal disorder, or then you have to look for other causes before you operate. That does not make an urgent operation for aneurysm. That's the point.
Yeah. Prashanta, do you want to share your experience with this small aneurysm symptom?
Actually, if aneurysm usually for the aged patient, having actually atherosclerotic changes, and etiology is mostly atherosclerotic, then visceral arteries may be involved, say celiac artery stenosis or superior mesenteric artery stenosis or renal artery stenosis. Then actually scenario will be changed, and sometimes it is along with coronary artery disease as well. So sometimes symptom may differ from, say, acute impending rupture aneurysm or visceral artery stenosis or renal artery stenosis involving some aneurysm in the perirenal area will actually present differently. Sometimes we face.
I think Mokbul has a very valid point. For further clarification, we should name it properly. So what we're talking about, the symptomatic, is actually called acutely symptomatic aneurysm, which comes with pain, back pain, this one. These are called acutely symptomatic aneurysm, and the treatment is immediate intervention. You should not wait 24 hours, then we'll regret that why didn't I intervene before. The other thing is symptomatic aneurysm causing some pressure symptom on surrounding organ for a long time. That need to be investigated. And if we find, yes, that's the reason is causing this duodenal pressure, then we have to do a semi-elective operation. I think that clarifies everything. Yeah. Now, Jubair, your presentation has been very good. Just have few slight reservation on few slides. In one slide, the percentage of rupture, because it gave a very wide range, like from 5.5 to 9 centimeter. And you mentioned about 35% risk. So 5.5 to 9 is a very big range. And on the same slide, the next column shows if it is 7 centimeter, the risk was different. So we need to understand the risk of rupture clearly, because when we tell our patient, we need to tell the patient exactly why we are operating and what is the risk of their rupture. Okay, so ideally what we say that if the aneurysm size is less than 5.5, we said that, look, your risk rupture is very low, is 1% or less. And if I operate on you, I'll give you about 5% risk of death. So best to just monitor it for the longer. If it goes between 5.5 to 6, the risk of rupture annually is around 10%. And then it starts increasing. Between 6 to 7 is around 20%. And then, of course, the higher it goes like 20, 30, 35. So that's important when we take the preoperative discussion and the consenting. We have Professor Niaz with us in the panel. Professor Niaz, do you have any comment or question, please?
Sir, I'm busy with my father. That's why I just listening only.
Okay,
I just thank you so much,
fine.
because my father is severely ill, so I am in Sylhet.
No, that's so kind of you that you're still with us. Thank you very much indeed. Yeah. Thank you. Thank you. Okay. Dr. Saklan is with us as well. Saklan, do you have any comment or question, please?
Sir, thank you for giving me the opportunity. The presentation was so nice, and thank you, Jubair, for your brilliant effort. Actually, I have just completed my cath lab, and on the way to home, there is heavy rain outside my car, so it's really tough for me to concentrate on the presentation. Still, the presentation was so nice, and I am enjoying really your discussion. Sir, I have a few questions. First question is, we are discussing about the size, and the size matters in case of aortic aneurysm. But sir, in case if we compare our physique with the Western, I think these markers are mainly the Western people. In our population, do you think the size should be a little bit smaller in compared to the Western population? So we should be more cautious with that figure, or a little bit small figure, we should be more cautious. My first question is, this is my first question actually.
Yeah, no, I'll answer your question one by one. So that's a very good question and is a very difficult question to answer. The main reason is we do not have much statistics and we do not have any trial on this. But in general, what you say is right, because the physique of our patient is a bit much smaller and, they are a bit lean and thin. Having said that, if you see that all our normal aneurysm size would be matching with the other group of population from other part of it, will be like 2 centimeter, 2.5 centimeter, because when we do operate on the aorta for some other reason, like aorta bifemoral, we do see a size of 2 centimeter to 2.5 centimeter AAA. And the whole aneurysm is the expansion of that size to 5.5. So it would be very difficult. For example, the AAA repair is one of the biggest surgery we are thinking of. And if we unfortunately lose some patient when we operate on 5 centimeter, and we have no evidence to justify that we need to be careful on that. So because we don't have our own data, we need to stick with this international data. We could say that, look, our normal aorta is only 1 centimeter. That would make a very, very valid argument. But our normal aorta is almost similar to the other population.
Okay, thank you, sir. Another question is, there is some emergency, if there is any symptoms or the symptoms aggravate, I could go discussion. What about thrombus? If there is any intramural thrombus, what cautions should we take? Is there any indication for early surgery or early intervention related to intramural thrombus?
Not really, because most of the aneurysm will have a large portion of thrombus, about 60 to 70% thrombus in almost all aneurysm. And that's not an indication to intervene. If you say that I have seen one patient or some patient with multiple embolic episode from a AAA which has thrombus, yes, that is a very rare scenario, but I have seen some patients that they have leg emboli or emboli in the spinal cord even. So yes, those patients need early repair. But if it is only presence of thrombus, large amount of thrombus, intramural thrombus, it's not an indication to do any early repair.
Thank you, sir. My last question, in our center of Ibrahim Cardiac, we are doing open and also the endovascular like EVER. Alhamdulillah, the patient was doing good. Patient is in vertical follow-up after the open, even after the endovascular procedure. The open case was 75 years old, and he's a big leader, and he's hopefully he will be compete for the upcoming election. But my question is, in our country, actually, the number of aortic aneurysm is not so much less. I think the incidence is little bit higher, but we don't have any screening program, and most of the time we have to depend on incidental findings. So what screening program should we have to run to find out the aneurysm cases in our country, so that we can take an initiative and ultimately will have some patients and we can survive the patients at earlier stage.
Yeah.
What is your suggestion related to screening program?
Yeah, I mean, my suggestion would be, it would be very good to have a screening program because that can reduce the complication risk of AAA. As Jubair mentioned, that if we can repair it electively, we have a very high chance to reduce the mortality rather than. So the best aneurysm screening investigation is a duplex, is just an ultrasound, a plain ultrasound. You don't need even a beam or duplex, just a plain ultrasound. So if we could start, in our population, like when the patient come to us in vascular surgeon, or we can encourage our colleague that, of course, the clinical examination, if there is slight suspicion, do an ultrasound duplex. It would be very good to do a duplex on a population who are 60 or more, but, we need to see the feasibility. So that would be my advice. But if you have any suspicion, do an ultrasound scan. What do you think, Dr. Abidul Rahman, sir, please?
I do agree that the ultrasound screening should be established. If it's not nationwide, at least for the vascular surgeon on themselves. And people who are coming with the other risk factor, 60 years old, 60 or older, with the hypertension, COPD, and the especially family history of aneurysm, they need to have a screen test. The vascular surgeon can initiate that any time. That in the United States, we have the same protocol. Anybody comes in, not necessarily vascular surgeon, a primary care physician, anybody older than 55 has a risk factor, gets an ultrasound scan of the abdomen to validate the aneurysm. So we can modify that, but that needs to be done. I'm going back to, if you permit me, I'll go back to the comment of Sakline about the size of arteries in general in Bangladesh population. Very relatively small Western populations. I know we cannot any antidote. We can arbitrarily decide the size, but that need a study. You guys can take up a study of the normal population of ultrasound scan of the abdominal aorta and see what the size of the aorta. That's how they decided 3 years ago. This is the size of the population of the male and female in Western countries, normal size. Then decides the ratio of the what the size should be aneurysm. Bangladesh population can also decide, taking that study, the normal population, what the size of the aorta and what should be the size of the aneurysm. It's 1.5 centimeter, 1.5 times normal the diameter of the aorta. So you can decide what size you will call aneurysm of the aorta in Bangladesh population.
Thank you, sir. If you have enough time, if you allow me, then I will ask another question. I want to share one of my case.
Please.
Sir, recently we have some idea related to management of aortoiliac fistula, aortoenteric fistula, sorry. That was a case of 68 years old female. She had a repeated history of passing of blood through rectum. And later on, she was diagnosed as a case of aortoenteric fistula. Several units of blood transfusion was given. The patient's general condition was not so much good. There was some comorbidities, electrolyte imbalance, but the patient was literally dying. The patient was referred to us from a district level hospital. And when we received the patient, she was settled. There is no.
Sorry, Sakline, you are breaking a lot. We did not get the last bit. Just try to answer again. Try to ask.
Share screen. Share screen.
Blood loss at that moment. So the patient for hello.
Yeah, Sakline, we lost
sorry,
a little bit, but we hopefully understood what you said.
Sorry, sir. Actually, my daughter is calling me due to heavy rain. The network was interrupted by my daughter. Sorry, sir.
No
Sir, actually,
problem.
that is the case of aortoenteric fistula, and we operate that patient. And there is a colorectal surgeon with us, and we find that at the terminal part of the aorta there is a leaking, and we repaired that leaking directly. Initially, we have a plan that direct repair will make the aorta stenosed. Still, we decide that will not hamper so much. So we there is some struggle during the repair, but Alhamdulillah, we did it nicely. And later on, the colorectal surgeon, he was searching for the opposite side that is puncturing the intestine. But there is no obvious puncture site. Adhesion was removed, and she repaired the teared part of the intestine. Actually, there is no definite connection or communication between the aorta and the intestine, but there is a huge adhesion between the aorta and the intestine. And we think that initially there was a communication, but later on it was sealed. Patient was doing good postoperatively, and we kept the patient in general ICU for our initial management, as because we don't have any ICU. Considering her general condition, from the first POD, we kept the patient in general. So she was doing good, but at the day 8 POD, she was expired, and the critical care medicine, they told that mainly due to consolidation in the lung, the patient was expired. There is no GIT complication or any complication in the foot or leg. A patient was a little bit on inotrope support also. So what is our problem from our side actually? What will be the probable cause of death? What should we do actually? Actually, I am expecting some suggestion from you for my future management of such kind of patients.
Very, very nice case. It's a very good topic to discuss. May I request Mokbul to say, what would you do in this situation? What is your advice, please, Mokbul?
That is a case of aortoenteric fistula. Dr. Sakline told about all things about this patient. The surgery was done in a tremendous effort. They did their job, but in the ICU setup, something happened. Maybe the post-op complication. There are so from this we should get the message. This is the after doing this sort of procedure, intensive care backup in collaboration with surgeon and intensivist. There should be a good collaboration regarding this case. That is a academic case as well as.
Prashanta, did you experience any case like this, any aortoenteric fistula? Dr. Prasanta?
No, we have no such experience other than for thoracoabdominal, thoracic real fistula we have, but never faced this type of aortoenteric fistula in our series.
Abid, your input, please, kindly on this. What is your advice? What should we do, Abid?
And aortoenteric fistula is definite treatment is surgical. There's no obvious alternative, although the endovascular, during early stage of intervention, the endovascular with a follow-up intensive antibiotic therapy has been recommended in some studies, and not really. The primary procedure is surgical, go down, take down the anastomosis, and either replace the segment of the artery involved with the autogenous material or repair the autogenous material. Misfortune of having the aortoenteric fistula following aneurysm repair, but I had to remove the entire graft and do the extra-anatomic bypass, and patients survive, a couple of them, in fact, in early stages of my practice. But the post-operative course obviously is going to be stormy, and that's why it needs an intense care and careful monitoring of the patient's status. It's just, I know it's difficult for Bangladesh situations having to have a constant observation of patients. And that's what things slips away from the physicians. That part of the care needs to be revamped, especially the critically sick patients. That's all I have to say at this stage.
Yeah. No, fantastic.
Actually, sir, we are preparing publication for that patient, but unfortunately, we lost that patient and didn't do any publication. Thank you, sir. Thank you for your suggestion.
Yes. So my concluding comment on this client. So firstly, I take that this patient did not have any aortic surgery before. There was no graft in the aorta.
No, sir. No, sir.
Okay. So this is a primary aortoenteric fistula, which
exactly.
is not common, but we do it sometime. And it was with the colon. It was not with the duodenum.
Duodenum, sir.
Was it with duodenum or colon?
Duodenum, sir.
What's it called?
Oh, sir, colon, sir.
Colon. So it
yes,
was
sir.
like in the lower part of the aorta.
Yes, yeah, terminal parts.
Yeah, so when there is a fistula with the colon, so without any doubt, that's an infected aorta.
Right.
And so the reason for this fistula was infection. So somehow the colon got stuck with the aorta and it causes. So the way I would deal with it, because there is an infection, we cannot primarily close an infected aorta, because the wall is, even if it looks healthy, it is not a healthy wall. There is infection, and it like to have some recurrent infection, recurrent opening, and it would be a torrential bleed. As Professor Abdur Rahman has said, that you need to do an extra anatomical bypass on this, because you can't reset part and put a Dacron graft or a prosthetic graft. So ideally, it should be excised. There is no way other than putting an extra anatomical bypass, keep anything free of any foreign material. And that would be the ideal operation. Always the prognosis is very, very risky, and the patient could die from other problems, but like lung complications, cardiac, can't do much about it. But as long as we do a right surgery and there is any other complication, we can accept it. I hope, yeah.
Sir, actually, the opening was tiny, and at that time, I did the direct closure, no patch closure or any other Dacron graft, because yes, obviously there is some sort of thinking in my mind also. There's some sign of infection may be there, but there post-operatively I was searching for, is there any sudden fall of blood pressure or any sign of infection, any sign of peritonitis. Actually, there is nothing, sir. Actually, every day we are doing. Yes, I really agree with that. There is some problem because they are general patients. They are dealing with, not post-surgical patient. I think that is a major problem.
Yeah.
So, if there is any sign of infection or any rupture, do you think she will maintain sustained blood pressure up to 8 PUD, no fever or other signs?
No. I'm not saying that the patient died of secondary bleeding or rupture. What I'm saying,
there is a chance. Okay, sir.
That complication would be inevitable.
Okay, got the point.
After some months or some time. Yeah.
Okay.
So yeah, that's a very good discussion. So I would like to compliment the presentation of Jubair with a separate presentation. If I can just share my screen, please. So Jubair gave a very good presentation about this elective open repair of abdominal aortic aneurysm. I'll just highlight a few points, and then we have a little bit more discussion before we. The indication was told by Zubair, and we know the indication is based on UK small aneurysm trial, which I mentioned that was published before. Now, we do measure it with ultrasound. So that's very important to remember that it's not a CT measurement or measurement with any other way. The whole study was based on ultrasound surveillance. And, it always, the CT will measure the aneurysm bigger compared to ultrasound measurements. So if ultrasound measures an aneurysm as 5 centimeter, the CT will easily measure it 5.3 to 5.5 centimeter. So that is the standard difference in between these two measurements. We discussed about the female, what should we do? Recently we started measuring the inner to inner diameter and outer to outer diameter, which means the inner to inner diameter is from the end of the thrombus to end of the thrombus, the lumen. And the outer to outer is from the aneurysm wall from this side to the other side. And this inner to inner measurement is more precise. And if the inner to inner diameter is 5.3 centimeter or more, then that is our threshold. We should start investigating and then plan an elective repair of abdominal aortic aneurysm. What do we do in octogenarians who are 80 or more? Are we still doing them at 5.5 centimeter if they're asymptomatic? So we have done few studies. I did one study in octogenarian, and it shows the complication rate was much higher. So, even after elective repair, their mortality can go up to 12 to 13%. So most of the center will agree that in octogenarian, the threshold should be 6 centimeter rather than 5.5 centimeter before we do the aneurysm repair openly, because, they are 80 or more, their risk of death will be higher. So the risk of death from the rupture will be higher than the repair if we operate them on 5.5 centimeters. So rather we do them on 6 centimeters. Now, preoperative assessment is the key thing of repairing an abdominal aortic aneurysm, patient selection. So there is an aneurysm, we can see easily that yes, we can make a top clamp nicely below the renal artery, we can put bottom clamps and we can open it and fix it. But that's not the thing, what we should look at. We should look at that, is this patient going to survive this operation? And that is very, very crucial. The patient may not have any history of heart attack, but if we take proper history that how long he or she can walk on a flat road, can he go up through the stairs without getting any breathless? And the most objective assessment to do this judgment is a cardiopulmonary exercise test. I don't know if we do it in some center in Bangladesh regularly, but in UK, we do not do any aneurysm repair, be it open or endovascular, without doing a cardiopulmonary exercise test. It gives few parameters so precisely, like we look at anaerobic threshold, we look at VO2, we look the forced expiratory volume, everything. And if they are above certain level, we can easily say the patient has a low risk mortality after open repair, or they have moderately low risk or moderate risk or high risk. And if it is high risk, then we should avoid doing an open repair of that patient. So if we do not have CPEX, we can do the other test like any other fitness test, including the lung function test, any other exercise tolerance test, so which is very important to select our patients. So in anesthetic preparation, we need to make sure that our expert anesthetist who has some expertise in vascular anesthesia put an arc line, an epidural line, a central line. Ideally, we should have a cell salvage, the cell saver, who can circulate the blood to get into the patient again to do this elective repair. And the table, operating table, should be breakable in the middle, so we can break the table. So the posterior part of the abdomen is lifted up, so aneurysm is on the surface to make the operation easy. Urinary catheter is mandatory. Some surgeon will prefer to put a nasogastric tube, and some surgeon will not. Many times we don't put a nasogastric tube these days. Now, in terms of incision, what incision do we give when we repair an abdominal aortic aneurysm electively? So one incision is transverse, another one is up and down in the midline. Now, in terms of transverse incision, we can give it above the umbilicus with a straight line. And also, we call it a little sad face, like the curve is going little up. So it's like a sad face. And we go to the below umbilicus with a smiley face. So the curve is facing down, so the concavity is upward. So what are the advantages of giving this transverse incision? So it's very, very advantageous. It gives less postoperative pain. It gives better chance of breathing, better breathing, so less atelectasis, the less chest infection, and it gives you good access. The access is not bad at all. You can get all the structures you need to see, and there is less risk of incisional hernia. So when I do my elective open repair, I do it with transverse incision. This is the last one. So I got a transverse incision across. It is slightly sad face. It's not straight, but many times I do it with a straight line. So you don't hesitate to go just at the side of the abdominal wall, and then you need to divide the rectus, and then you get the peritoneum, divide the peritoneum, and you have every access very nicely. So steps of the operation. So once we go into the abdominal cavity, we need to hold up the transverse colon outside the abdomen. And we put a big, large drape on the right side of the tummy and take all the small bowel out on that, and we cover it with another big drape. Some surgeons keep the transverse colon outside. I prefer to put it inside and then cover it with a large wet swab all the way in the upper part of the abdomen. The next thing, we need to go to the duodenojejunal flexure, and we start dividing the peritoneum between the aneurysm sac and the duodenum very carefully, not avoiding any injury to the duodenum. And by that way, we can expose the neck of the aneurysm. And you may see sometimes very, very large lymphatics. So either clip it or ligate it, because you can see some lymphatic non-stop drainage, some lymphocyl, a big lymph collection into the abdomen after open AAA surgery. So if we have to divide the left renal vein, we will do that, but not as a routine. And in the CT angiogram, we need to always check if the left renal vein is retrorenal. Okay, so if sometimes it goes to the kidney through the back of the aorta, and that can cause torrential bleeding if we don't know that before. The superior mesenteric vein normally doesn't need dividing, but if you can, if you have to, you can divide it. And then at the neck, we need to get window on both sides of the neck up to the lumbar spine. Make sure that your scissor or forceps hitting the lumbar vertebra. Now, if we have facility of omnitract, we apply the omnitract, and the main shaft should be on the left side of the body of the patient. Then there are few retractors, the splanchnic are the common few one, and then we use a big Finch retractor to remove the gut. And if there's no omnitract, the Kelly is very good for the top, Morris is good for the bottom, and you use some few Deaver retractor. And then we open the posterior peritoneum over the aneurysm sac in the midline, all the way up to the bifurcation. We will try to save the nervi arginitis, which gives the sexual function of the patient, if possible. And then we get both iliac artery exposed, and we have to identify the ureter, otherwise there is high risk of damaging the ureter. Now, in terms of clamping, we give heparin before clamp, and we have to clamp the iliac artery first. So this is very important, that don't clamp the aorta first, clamp the iliac artery first. It will help preventing thrombus going into the leg. If we clamp the aorta, the iliacs are still open, so there is risk that thrombus can go into the legs. We do always try to put it infrarenally if possible. If not possible, try to keep at least one renal artery in circulation. So sometimes you can carve the retractor. So one end of the clamp goes one above one renal artery, the other one is below that. So one renal artery is perfusing one kidney. The Mattox clamp is the preferable clamp for the top. Do not look for lumbar arteries. You can close them from inside, but you need to identify the inferior mesenteric artery. Now, when you open the aneurysm sac, we open it in the midline, then the sac is open, a small amount of blood comes out because all are clamped. We scoop out the thrombus, and the ideal instrument for that is a British rail soup spoon. It's like a proper spoon, you just spoon it out. And then we can ligate the lumbar arteries from inside with figure of 8 sutures. We normally use a proline, and it gives good closure. The median sacral artery will bleed. If it bleeds significantly, you have to close it. Otherwise, just control it with some pressure. So your bottom anastomotic line is still free. Excuse me. So then the graft anastomosis, we need to measure the neck size of the neck of the aneurysm. You can measure it visually, or you can measure it with some measuring instrument. If there is a possibility of putting a tube graft, we always prefer to put a tube graft. If it needs a bifurcated graft, we try to stay within the abdomen and pelvis rather than the femoral arteries. So you can anastomose in the common or external iliac artery. So when we put the bifurcated graft, sometimes we forget to cut short the proximal graft, and then we anastomose, and then we see, oh my goodness, it's a too long graft to going into the bifurcation, and then we have to redo the anastomosis. So surgeons prefer technique, you know, how you anastomose it, and you know, you can start from any side. Sometimes aorta need dividing, so we do end to end, and Shatinsky is the right clamp to do that. When you do the bottom anastomosis, you need to be very careful about the both top and bottom. The principle is to big bite, and the bite need to go a bit obliquely so we don't narrow the graft. Now the question is reimplantation of the IMA, inferior mesenteric artery. Do you have to reimplant the IMA or not? Most of the time not, but there is a very good scientific way to judge how you do it. We can measure the stump pressure of the inferior mesenteric artery. You can just put a little cannula into the artery and connect it with the central line device, and it can measure it. So if the pressure is more than 70, or the ratio of that pressure and the ratio of the arm pressure is more than 0.4, we don't have to reimplant. If it is less than 0.4 or less than 70, you best to reimplant the IMA to avoid gut ischemia in the postoperative period. So we reimplant only, you know, if we're happy with this, we're not happy with this pressure, or if the artery is very good size, you don't want to ligate it, and it's not technically difficult, and it's not taking a very long additional time after your operation. So the operation was straightforward, and few extra minutes will not be harmful. So sac closure again, so we start from the top and from the bottom. That gives a good closure in the middle, and then we close the posterior peritoneum. We put the bowel back in a way so mesentery doesn't get twisted, and then we close the abdomen, most of the time without a drain. Try to avoid a drain in aneurysm surgery because you have a large prosthetic graft and you don't want to have any route of infection there. The post-op care always need to be in HDU or ICU. So if we don't have a bed preoperatively in HDU or ICU, we don't do that elective repair on that day. Possible complications after operation could be bleeding, could be gut ischemia, could be abdominal compartment syndrome, could be renal failure, limb ischemia, and Jubair has mentioned a few others. So we can tackle them accordingly. To conclude, with the meticulous preoperative assessment and appropriate surgical technique, the perioperative mortality of elective AAA can be less than 3%, or the morbidity could be significantly reduced. So we need to put big emphasis on our preoperative assessment, the proper surgical technique, and proper postoperative care. Thank you, everybody. So that was the discussion. I'd like to open it to the panel, please. And so start with Dr. Prashanta, please. Dr. Prashanta, your comment and question on this, please.
Actually, your elaborate operative procedure will help really our audience, especially young surgeons. Actually, during the era of endovascular surgery, you have to be very competent as well with the open technique. Otherwise, complications of one of the procedures will not be tackled by other procedure as well. But actually, I was asking for the same reason, the perirenal area, which is sometimes very actually challenging, like say celiac artery or superior ostial region having aneurysm. What should be the actually panoply for in those cases?
I mean, if the aneurysm is infrarenal, then we just go into the neck and we go. The problem starts if it is juxtarenal, and suprarenal is a different ball game. So suprarenal aneurysm is a different ball game. Ideally, the suprarenal aneurysm should be repaired with a retroperitoneal approach. So you go through that area, you mobilize the kidney, and do a supraciliac clamp. For the juxtarenal, sometimes we have to put a supraciliac clamp for a short period. So as soon as you clamp it and open the aneurysm sac, you'll see that you get additional length, and then you can just put the clamp below. If you still have to be in the suprarenal area, then we need to do the anastomosis very quickly, to stay within the warm ischemic time. But ideally what we try, we clamp it above the renal arteries and then try to come below as soon as you open the sac, because you get some additional length. And one good technique is, if you pull the aneurysm down with your hand, you'll get some additional length on the neck. And worst case scenario, I put the clamp in a slightly curved way. So my one end of the clamp goes above one renal artery, but still stay below another renal artery. So at least one kidney is perfused. Don't try to clamp SMA or celiac trunk separately. That will make a disaster. So if you are in that position, you have to go to the supraciliac aorta and clamp it, which is not easy. But preoperative, looking at the CT angio planning, where you're exactly going to clamp, is very important, because you have no chance of thinking when you're in. You have to think everything beforehand. So few additional technique. If you pull the aorta down, you get some additional and a very good dissection. So if you have difficulty in the neck area, always divide the left renal vein, please. Always divide the left renal vein if it is a difficult neck, because that gives you some additional view of the neck and you can clamp it nicely. Dividing the left renal vein doesn't do any harm. Dr. Abidul Rahman, your input, please, on this. What do you think? Sorry, you muted, Abid Bhai. Abid Bhai, you muted. Yeah.
I agree with you. The retroperitoneal approach is ideal for juxtarenal and suprarenal aneurysm. Even in the infrarenal aneurysm, we have done quite a few, in fact, in Bangladesh with the retroperitoneal approaches. Makes it post-operative recovery a little bit easier in the sense it doesn't give you as much third space fluid shifting as much as the intraperitoneal approach. Pneumonia incidence is a little less, and pain tolerance is also better. But in any case, the suprarenal approach is always a retroperitoneal approach. The other things I was going to say about the IMA implant, and you can already predetermine on the basis of a preoperative CTA, and if there is any significant degree of stenosis of the celiac or mesenteric, then you need to be prepared to implant the IMA because that already compromised mesenteric circulations. And in that situation, you'll find the IMA pressure reading will be higher because the IMA was one of the main feeding vessels. And also CT scan will give you the idea of retroperitoneal renal vein and any inflammatory changes of the aorta. So you're prepared ahead of time. The other thing I was going to mention, the damage to the hypoglossal nerve. If the aneurysm involves in the iliac artery, you really need to avoid dissections or the aortic bifurcations and cross clump at the iliac bifurcations and open the aneurysm, the aorta. Try not to dissect the iliac aneurysm wall. Just passes the graft through the aneurysm. So it really drastically reduces the hypoglossal nerve damage to the either side. You really don't have to open the iliac aneurysm. Pass the graft limb through the aneurysm into the iliac bifurcations. That definitely avoids any hypoglossal nerve injury.
Yeah, thank you so much. So
one more question from my side. Sometimes we are getting actually abdominal aortic aneurysm. What should be the treatment strategy for us?
Okay, so if I may answer that, so yeah, that's a very common situation because we know that the peripheral vascular disease is associated with cardiac disease and vice versa, and abdominal aortic aneurysm is in reality is one form of peripheral vascular disease, atherosclerotic disease. Yeah. So there is a history of cardiac disease in a patient, and patient has this aneurysm. So what we do this, if there is no acute cardiac symptom, we do this cardiopulmonary exercise test, right? If there is no facility of cardiopulmonary exercise test, you do a myocardial perfusion scan, right? And you see that there is some ischemic segment in the heart muscles. So what I do, or what we should do, that ask cardiology colleague to optimize the cardiac function before we do the aneurysm repair. So if there is some ischemic zone in the heart, so which means that this patient has coronary atherosclerotic disease, and they can revascularize the heart first with the percutaneous approach, and then we do the aortic aneurysm repair. So that should be the idea. So I always, if there is obvious sign, I do a myocardial perfusion scan. Or even a dovitoministrus echo, but a MRI perfusion scan will be more helpful. And then ask my cardiology colleague to treat the heart first, and then we do it. The next question is, if it is not optimizable, what we should do, then we should avoid an open repair by all means and try to do it endovascularly.
But patient having aortic aneurysm, is it preferable to do exercise tolerance or dobutamine, as it will cause over pressure over the aorta, and dobutamine is also cause increase the force of contraction of heart, as well as it will also create pressure over the aneurysm.
Yeah, so that question has been raised, but there's a lot of study. We can very clearly tell the patient that no, this exercise, cardiopulmonary exercise test, or the dobutamine stress echo, or the myocardial is not going to affect your aorta at all. You are fully safe. It's not going to do anything.
But we tell the patient always to control blood pressure.
Yeah, so, but this thing, for example, the cardiopulmonary exercise test is done in a very controlled environment by an expert anesthetist, and also the dobutamine stress echo done by the, so that very short increase in the blood pressure will not cause any damage. It's the persistence of the high blood pressure causes the damage.
And especially ascending aorta is more vulnerable for those acute pressure rise than the distal aorta.
But one thing Dr. Prashant was telling about the aneurysm involves the renal artery, pararenal area, maybe control over the celiac or anything else. But what about the renal artery? Do we need implantation of the renal artery, and what will be the protocol regarding implantation of the renal artery?
Yeah, so if it is like a proper pararenal aorta involving one of the renal artery, we need to reimplant the renal artery. So what we do, we just take it off with a big patch on top of it, put your graft, open a side hole in the graft, and put that patch back into that.
Any sort of hypothermia or cooling of the patient is needed, or the cooling of the kidney is needed during the procedure?
If you manage to do it within your warm ischemic type, it's not. But it could be preferable to have some, cooling saline infused into the kidney to just keep kidney perfused during that time. You can put a little cannula and put that cool renal solution into that to perfuse the kidney.
And you are telling about the division of the renal vein, and division and ligation, or further reconstruction of the renal vein at the end of the procedure.
No, ligation. Just double ligate. So double ligate on both sides, or ligate plus a big clip. Ligate plus a big clip.
But usually we avoid this. We are feared this. If we ligate that, there is chance of enlargement, dilatation of the renal vein as well as the kidney as well. That the problem is the kidney.
I mean, the study shows that if you ligate the left renal vein, there is no consequence as such, because you have the adrenal veins, which takes the good drainage.
Have you ever ligated left renal vein? Any of us here?
I have done many times.
I have to ligate many times.
But as Mokbul says, one thing I need to highlight.
Abdominal aortic aneurysm at that time.
Yes, you tied it, Prashant.
Thoracoabdominal aortic aneurysm, sometimes I have to ligate actually left renal vein, because retroaortic.
Yeah. One thing is important when we divide the left renal. So we put a ligation on the side of the vein and put a ligation on the left side of the vein, but we need to put it sparing the adrenal vein. You can see the adrenal vein coming. So don't go beyond the adrenal vein, okay? So always keep the adrenal vein in circulation so that the venous return goes through that one. Then
this is very good. Yeah, it will be helpful. We have to spare adrenal vein.
Yeah, and we need to see where is the adrenal vein attached, and then we do it just medial to it, not lateral to it. Okay, so
one thing all the discussion shows, these are option of incision. There is a transverse incision. There is a big incision transversely. Usually we do it by the midline incision, but you are telling midline incision there is chance of hernia. But in case of transverse incision, is there any benefit of exposure of the field with the transverse incision if we like to go up more and more?
Yeah, I mean, the benefit of transverse incision is very, very good actually. Abid bhai, do you do your elective aneurysm with transverse incision or up and down?
No, I haven't. I have done midline and retroperitoneal. I know it's been utilized.
Yeah, the advantage of transverse is, you can extend slightly on the lateral side and get very good exposure in addition to your good exposure if you need to. The second thing is the postoperative recovery is so good because there's very less abdominal pain, they breathe very well, and long term, there is no hernia, and advantage is quite good. And your exposure to the top of the aorta and the bottom of the aorta is very good. So, when you look at the CT scan, if you think that iliacs are a little bit down, you have to go down quite above the pelvis, then do a subumbilical smiley face. So go below the umbilical, little smiley on the top, and it's very good exposure. I like that, the transverse incision. Okay, so we have Bashar. Bashar, we missed you a lot. I'm sure you have done some operation or something.
Actually, sir, it's good to see you all. Assalamu alaikum. I actually got stuck in the cath lab. We addressed a very complicated aortoiliac occlusion, hostile abdomen, so we really needed to do it by endovascular means. So I thought that would be done in an hour, but it took about 2 hours. Anyway, I was missing you while I got your call. I'm really sorry about that.
No,
I missed the first presentation from Dubai, but I did follow your presentation, and I'm really enjoying the discussion that is going on.
So what do you think? Will this help us in terms of doing our open aneurysm repair, or
certainly, I mean, of course, certainly, because this sort of sessions actually brings in a lot of things. I mean, that our preferences, advantages, like you say, the transfer sensation is not very much in practice in our country. Mokbut mentioned, because we always try to do it by midline incision.
Midline is fine. Midline is absolutely fine, but,
but see,
if you like to try that, you get this advantage.
But this is another way to do it. So we got an idea about that as well. Abid sir also did it. And another observation from my side is that, I mean, Prashantoda also raised this point that if we have concomitant coronary artery disease, I remember having published one article while in Japan, actually, from my department. This was a routine practice. Ours was the aortic surgery group. And whenever procedures are being done on the proximal aorta, and if there was concomitant abdominal aortic aneurysm or coronary artery disease, I mean, I know cases that I published. I was the first author of that case: CABG, abdominal aortic aneurysm, and carotid endarterectomy. 3 procedures in one sitting. That was, they're not very routine, but I think this is another way to look at it. I mean, whenever possible, I think we can combine procedures. So how about that? I mean, your thoughts on that?
No, we have done few combined CABG and open AAA, but I've never seen anybody doing combined CABG, carotid endarterectomy, and
that has been reported. It's there with me. I have
because we do the concomitant carotid and AAA and carotid and cabbage. I would say the trend is coming down now. It was quite popular in one stage that you do the combined operation. Now the trend is been down because it didn't give any added advantage. The risks were more. So you do only in selective cases, like I previously mentioned, when you do the concomitant carotid and aortic operation. And CABG and aortic, sometimes it's needed because the heart is like this, you cannot wait, and aneurysm is so big, you cannot wait. Then you do the concomitant. It's just planning of the heparin and the bypass machine and everything. So we let them open the chest, do some bypass, and then we fix our aneurysm. So yeah, that's very good. So Bashar, you do some aortic surgery, you do aneurysm. So what is your experience, and where do you think that we should focus more?
Well, I think in your lecture that I followed, actually, you have covered mostly the things, the technical aspects has been covered. Actually, there's nothing much different. Actually, all the important aspects have been covered. We would not do things much differently. But one thing that actually came to my mind is that sometimes the large aneurysms that has been there for a long time, it tends to get rotated, twisted, or something like that. It really distorts the normal anatomy of the abdominal aorta. So at least I can remember one case when I found the rotation took along with it the ureters. It's actually coming in front of the aneurysm. Whether we don't expect the ureters to come in front of the aneurysm wall. I mean, that is something. So when we were trying to longitudinally divide going through the wall of the aneurysm, there was almost we cut the ureter open. So that is one thing. I mean, I want to put a caution or mention as a special point of caution that really needs to be kept in mind.
So yeah, that's important. That's why I mentioned that we need to identify the ureter, whatever is the anatomical position. Abid bhai, you like to give us some knowledge and your advice on operating inflammatory abdominal aortic aneurysm on an elective surgery, which is a very difficult operation.
It is a difficult operation. There is no question about it. And if you are going to involve the inflammatory you must have the cell saver because it usually causes very onset in order to get to the aorta. They cause a lot of hemorrhagic and in order to get to the proximal neck, it is always difficult depending how much duodenum is involved. And once you can get the duodenum mobilized carefully away from the aorta, it's reasonably, that becomes routine after that to get the proximal aortic control. Then I would say, in order to get the left iliac artery, you need to reflect the rather than trying to get to the iliac artery from the proximal. You need to reflect the left colon and right colon, right iliac artery. You have to be mobilize the cecum. Once you get those controlled, then you open the aorta. I think this is a little bit different than routine. That's how I did 2 or 3 of them, but I don't have any extensive experience of inflammatory bowel disease. But post the inflammatory aneurysm, you have to be a little different than routine approaches.
Amongst our other panelists, Mokbul and Prashant, Bashar, any experience with inflammatory abdominal aortic aneurysm? So it's a very difficult aneurysm. What I do, I just use one technique. I don't know if you agree with that. So because it's stuck between the duodenum and the aneurysm sac, you can't normally divide the peritoneum as you normally do. So what I do, I don't know if you have experience of some inflammatory abdominal aortic aneurysm. I make a little superficial cut onto the aneurysm sac, say about 2-3 centimeters from the duodenum, and then I use a Watson chain to lift it up. So use the Watson chain to lift it up towards the duodenum. And then you can separate the duodenum from the aneurysm, lift it up, and then you get your aneurysm sac free from the duodenum. Because the problem is the inflammatory aneurysm is stuck with the duodenum, and you can't divide it. So if you make a little plane onto that fibrous inflammatory tissue and use a Watson chain slowly to detach it, and then get the duodenum separated, then the rest of the aneurysm is like a normal aneurysm. So
I agree with that. That's the most difficult part. And I never used that technique, so it's been excruciating to get to the control of the proximal neck.
Yeah, it is difficult. So we do have Shakil Farid, who is a very renowned cardiothoracic surgeon in UK now, and he is really expert on few things. So Shakil, if you can hear me, thank you for joining us. Are you still there, Shakil?
Not.
So he may have just left. So yeah, I was going to ask him his experience about combined CABG and abdominal aortic surgery. So which I said that the trend is getting less. Do you have some experience, Prashant, with the combined case?
Combined case, we have actually less experience, as the longer case will actually threaten postoperative course and others. We used to actually, we have to refer our case to our vascular surgeon colleague. Usually we have to fix if it is say left main disease or critical left main CABG first, then vascular surgeon has actually dealt with those AAA. Or sometimes we have to actually change our protocol according to you actually advise us also like that. If abdomen is acute emergency and the heart is actually with not burdened with critical stenosis or something like that, then it should be stabilized by the cardiologist or cardiac surgeon, and vascular surgery will be attempted first.
Yeah, fantastic, good. So
I have a question to the panel. If you do combine procedures, are not necessarily combined. If you do find a large abdominal aneurysm has a higher risk of rupture, and at the same time, patient need a cabbage, do you combine that, or do you think you can stage that for a few weeks?
So, as I said, that we have this trend of doing this combined procedure a few years back. So we just do a combined cabbage and aneurysm. So the results were not very positive. So that's why the selections are quite limited now. So if the cardiac ischemia is so intense that the patient cannot wait, they need a cabbage, and the aneurysm is quite big, we still do the combined in selective cases. So we just reperfuse the heart and then we reverse the heparin for a short time, do the aneurysm repair, and then put the heparin again, complete the cabbage. We just perfuse the left main stem first, as Prashanta says, and then do the aneurysm repair, then go back to finish the cabbage and then close everything. So, but it's not as popularly practiced as it was a few years back. So the ideal would be a staged operation. Now the question is which stage first. So if there is significant cardiac problem and we think about a stage, we need to do the coronary first. Otherwise, this patient will not survive an aneurysm repair.
Then how long is the wait?
6
for
weeks.
the aneurysm? 6 weeks.
6 weeks.
Okay. All right. Great.
So, Saklan, did you manage to get this second part of presentation, or you missed some of it? Do you have any questions, Saklan? I think Saklan, you still there?
Sir, thank you. Actually, I was really enjoying the discussion. In this subject, I am really a beginner, have a little bit experience regarding the aortic cases. But as I have to face a lots of problem with the limited resources, I think this is a great help for me. And definitely, I request you to send me your last second segment of presentation and another elaborate class with the juniors like we. I think that will be a great help for me. Thank you, sir. Thank you for the nice arrangement, and we are really grateful to you.
Okay, thank you very much. Just question to Mokbul and other colleagues in Bangladesh. Do we have any facility to do cardiopulmonary exercise test in Dhaka?
Obviously, there are cardiopulmonary exercise tests. So all cardiac centers, they are doing the procedure regularly.
And we can do it routinely if we want to do it before our aneurysm operation.
Routinely, definitely.
The other thing, do you have facility of cell salvage?
Cell salvage, Prashanto can tell it. In NICBD, there are cell saver machine, but it was limited use was there. Maybe other centers, we are not using the vascular people, but Prashanto can tell the cardiac centers.
Actually, 3 more centers actually having cell saver, but disposable is around actually above 20,000. So surgeons are actually reluctant to use it. But for the aortic surgery, it is really helpful.
It's a mandatory thing.
Mandatory, helpful.
Because it can save life, to be honest.
Yeah, definitely.
So, Abid, do you think that we need to be more proactive in terms of getting the cell saver when we do the aortic surgery?
Yes, I do. I do. I mean, that's that. Once you have the cell saver available, really hardly need any transfusions. Even if you lose some blood during the procedure, that's captured and reinfuse those, and hardly any patients need a secondary transfusion. I think most of the cardiopulmonary center has the cell saver arrangement, so vascular surgeons can borrow their cell saver unit during their procedure. As Prashanto says, is the availability of the filter that restrict the use of cell saver.
Yeah. So I think that's one thing. And the other thing, are we doing enough cardiopulmonary exercise tests? Because this is quite available, Mokbul. Do you think we're doing enough number of cardiopulmonary exercise tests?
Yes, it is available.
No, but we vascular surgeon, are we doing enough or not?
No.
No, we are doing. We send the patient to cardiologist. Usually they prefer. Usually in such question, they prefer a routine coronary angiogram. But sometimes they also do exercise tolerance test also.
Yeah. I think, what I would like to...
But a small comment from my side. Actually, Dr. Mokbul and me are working together for many reasons, for many areas. But actually, non-invasive cardiology, that is clinical cardiology, a bit actually neglected or less respected in our country. For those reasons, they are not also taking initiatives to take this participation. Say send your patient to me. I will take care all those non-invasive tests to actually take care of your cardiac patient. So this should be reciprocal. We should actually ask them for their help, and they will be also our part at that time. But at this moment, invasive, that is interventional cardiologists are taking much more part of this practice. This is the actually reason behind that. So we are taking less help of cardiopulmonary.
Yeah.
I need to clarify something. When you say cardiopulmonary evaluation, it really in Bangladesh is a cardiac evaluation. They don't do pulmonary, do you?
Yeah.
That's my question.
Sir, for my practice, I have to, because I have to go for minimal invasive surgery. At that time, single lung ventilation is needed, and everything is actually, for my practice, I have to go for cardiopulmonary as well.
But when a vascular surgeon will send to a cardiologist for cardiac evaluation, but they don't get involved in the pulmonary evaluation. So you really need to develop a special non-invasive cardiologist involved to develop the cardiopulmonary evaluation at the same time, not just the cardiac only. Your open aortic aneurysm requires both of them. It's just not one versus other. So that's something vascular surgeons are to think about, how to streamline that evaluations for you guys.
Absolutely. So just to clarify from Prashanta, for my knowledge, when you request this cardiopulmonary exercise test, do you routinely get a result of anaerobic threshold and VO2?
No, sir. You have to be actually vigilant enough. Otherwise, they will not go for routine testing. It is actually our failure as well, because pediatric cardiology people actually go for everything. But for adult group, invasive cardiology part is so strong part. Actually, clinical cardiology is actually no more existing. Say, Dr. Mokbul will agree with me. There is less practice of stress echoes, and many of our echocardiologists are actually reluctant to do so. Say dobutamine stress or TOE, it is actually really not up to the mark in our practice at this moment.
That's the waste of resources, isn't it?
Yeah, I strongly feel, Abid bhai, if you agree with me. So if we plan to do any aortic surgery, Mokbul, I think we would selectively ask for a proper cardiopulmonary exercise test, which should include anaerobic threshold, any inducible ischemia, a proper VO2, and this type of important parameter. Otherwise, we'll never get the proper information what we want. And if we don't request it properly or tell them clearly what we need, we would not get it. Then we do a nice operation and patient will probably die for some other cardiorespiratory complication. And then we'll at one point we'll realize that our assessment was not quite intrusive. So that's one, and trying to get this cell salvage when we operate on the aortic aneurysm could be one thing we can look at. So those could be the positive things to look forward. So we come into the end. Yeah, sorry, something. So
before ending, the last Rutherford 10th edition, which is just published this year, January 2023. The current indication for open aortic repair, they argued the unavoidable anatomy for EVAR or FEVAR is indication for open aortic aneurysm repair. Unavoidable, or they are telling the first option is EVAR or FEVAR if there is no hostile anatomy in the aortic. This is the latest information.
Yeah. So this thing will change soon, because now we have a very new strict NICE guideline, and the NICE guideline is you do an aneurysm repair with open repair if the patient is fit as a first line of treatment.
Right.
So that is the trend is going all over the world now. It's changing because people are looking into the long-term data. And you know, in some place, I was in a meeting with Bhai, and I like that. Okay, so they says we should call it EVAS, not EVAR, right? They could say we should call it EVAS, EVAS, not EVAR. Why? It's endovascular aneurysm stabilization. It's not repair. It stabilizes it for some year. Okay? Because the long-term data are coming, and you know, you need to see the cost benefit as well. So the nice guideline is the first line of option is open repair. If it is like, you know, some cardiac wreck that you cannot do it, then you do the EVAR. Because anatomical suitability is always for open, isn't it? Any aneurysm would be open suitable if it is suitable for EVAR or FEVAR. So yeah, I think that this thing will change, but also in our context in Bangladesh, I think we should focus more on open repair because it's less expensive compared to EVAR and it's more durable. And so if we want to do it, then we need to do it appropriately, which need a proper assessment and proper operative technique with additional support, and we can get that. So that I think we should think of.
No,
So,
I fully agree.
Professor Abidul Rahman, your closing comment and remark before we end, please. Give us your valuable opinion, please.
I fully agree with that. Especially the young patients with the less comorbidity first should be open, irrespective of where you live. And in the United States, the same trend is held for last 4 or 5 years. I think it's going to get more prominent. And in Bangladesh context, the financial burden and then the technical lack of support for the endovascular is still there. So
absolutely.
I will urge you all, young surgeons, to get expertise in the open repair. And besides, endovascular repair also end up, certain percentage of end up being a open repair. So you have to be expertise doing the open surgical repair of the aneurysm before you become very expert in endovascular. So that will be the recommendation from Bangladesh.
Thank you very much, Abid Bhai. Thank you for your expert opinion. Dr. Mokbul, your closing remark and comment, please.
Nothing more. We learned a lot from this open technique, and we are practicing here, but the total number of cases regarding aortic aneurysm detection is day by day it is increasing. But when we try to operate the cases, if the patient is asymptomatic and size, bigger size, but patient is asymptomatic, most of the time they are reluctant to do go under this big operation with big investment of money as well. But one thing, awareness, it is increasing, and the routine ultrasound test day by day, it is also detecting more and more aortic aneurysm cases, and physicians are referring the patients to us. Hopefully in future, number of open and endovascular cases will be more and more in case of aortic aneurysm. Thank you all.
Thank you very much indeed. Dr. Jubair, you've been the speaker today. Do you have any question or comment?
Thank you, sir. Regarding the aortic aneurysm in Bangladesh, recently I got a patient whose infrarenal aortic aneurysm, the size is 8.1. And the patient is a retired Navy person. So I offered them the intervention, but I totally agree with Mungu sir, as there is no symptom. So patients are not interested to the further procedure. But you know, I already mentioned the mortality rate and everything in the prescription. It's really difficult in Bangladesh to make the patient the conscious and total there is a disaster condition if there is a rupture. Though this patient younger brother is a teacher of Dhaka University, This is the actual scenario in Bangladesh.
So what mortality code you have given Zubair?
Yeah, I told them the chance of rupture is so high because it is 8.1 and the mortality is around 80%. So it's really very bad. But the issue is again the financial issue and others issue.
Yeah.
So it's sometimes very difficult to manage.
I mean, you have done the right thing from your side. You have mentioned the risk of
another thing,
rupture
what I
and
know at
mortality.
Singapore regarding the screening, at Singapore, if any patient came to the emergency with abdominal pain, they routinely do the CT abdomen, and they got the aortic size. If the size is just 3 or more, this patient is usually on routine follow-up, and they got the lots of aortic cases. I think this is another way to screening. So ultrasonography is really very inexpensive and simple test, but
I mean, I would a little differ with your comment, Zubair, because when patient comes to A&E with abdominal pain, nowadays the routine investigation is CT, but that's not part of aneurysm screen. And of course, CT will show then the aortic size, and this is like an incidental pickup, incidental finding. What people do is like, in UK, when some gentleman is 65, they receive a letter from their GP that you are invited for an ultrasound scan of the abdomen. Okay? So, I mean, in our country, maybe we can think about 60, but it will be difficult to invite everybody. But whenever, especially with the vascular cardiac community comes to a patient and request it, it will be helpful. That's very good point. Okay, so Prashant, your comment, closing comment and remark, please.
Actually, thank you, Mahfuz Bhai and PHA for a very time-demanding actually topic. Good discussion. We have learned many things, many tips, which will be helpful in our next day practice as well. And also, we have to actually we have to adopt many things. We knew from book many things, but we are not practicing at this moment. Inshallah, next day, from next month or next year, we will adopt all those things, which will be helpful for our patient care. Thank you for your time, demanding topic and your talk. Thank you very much.
Yeah. So with that, we'll close our session today. Again, a lot of thanks to the participants, our panelists, speaker, and hopefully we'll keep trying our best to improve as much as we can. And again, I thanks PHA. So Bashar, you have any closing comment, remark?
No, sir. Actually, I was listening to the closing remarks by the panelists. Nothing much, actually. One thing I can say that compared to the autoileic occlusive disease, we come across the aneurysms far less commonly. So our exposure and experience with aneurysm open repair is really limited, and we do it once in a while. So I think it is very important that these topics are discussed often to enable us to look back on the technical aspects and all those things. So thank you very much, sir, for bringing this into the discussion, and also PHA and involving us. We look forward to similar sessions in the future as well. Thank you.
No, I think we all are very grateful to PHA, which is giving us this platform to discuss, and we'll continue to keep our effort to get us more oriented, more experienced, more trained. So thanks once again, everybody. Abid Bhai, thank you very much indeed.
Thank you for inviting us.
So all the best to everybody. We say goodbye today.
Thank you.
Thank you very much. Okay.
Assalamu alaikum.
Bye.